there's just so much.
You're listening to a Mamma Mia podcast.
Painful sex is never something you should have to put up with. It's really common, and there are so many possible causes, from hormonal changes to dryness to pelvic floor tension, infections, psychological factors like anxiety, past traumas, even relationship issues. Our bodies and minds are so deeply connected, and sometimes pain is our body's way of saying, hey, something needs some proper care and attention here.
Hi, welcome to Well, Your Full Body Health Check. I'm Claire Murphy.
And I'm Dr. Mariam.
And today we are dealing with painful sex, when it's too dry, too tight, you're too much in your head, and sometimes due to a fun list of infections. Whatever the cause, we are going to be looking into it today. We'll also check in for a quick consult with Kayla, who's been avoiding a specific doctor's appointment because she's afraid, Mariam, of what you can see. So we would like you to be incredibly truthful today.
Will do.
But first up, it is time to go to med school. We're going to bust a TikTok myth today about what's going on inside women's mouths.
Welcome to med school.
All right, we're doing a little bit of myth busting here today. There is a TikTok video by Dr. Ellie Phillips doing the rounds. It's about how women's saliva pH is different to men's. And so therefore, in this video, she claims that women are more at risk of tooth issues like cavities.
Yep.
So the basis for this series, because in the 50s, saliva pH levels were researched using dental students. And what was the overwhelming gender of dental students in the 1950s?
Males?
Correct.
Yeah.
So they found on
Surprise.
average men's saliva pH is around 7 or slightly higher. And it turns out women's saliva pH can be a 6 or even a little bit lower. So our saliva is a little bit more acidic. And Dr. Phillips claims this could be the reason why your teeth are weakening, or you're getting more plaque, or why you're maybe getting gum disease. But dentists are saying that there is currently no correlation between this slight difference in saliva and those issues. So they need to do some more research on that.
Yep.
But if you have a look at, say, Colgate's website.
Yep.
So part of this whole discussion too is that toothpaste is designed for men's level of pH and not women's. So on Colgate's website, they say acidic pH levels lead to demineralization. Your enamel starts to demineralize when exposed to a pH level of about 5.5. So if you remember, women's pH is around 6 or slightly lower. And that can cause many oral issues, including tooth sensitivity and decay. That's why too much soft drinks, sports drinks, lollies, citrus is unsafe for your teeth. It is a US site, so I've had to switch out. If you do go and look at this
Candy.
yourself, they say candy and soda.
Yeah.
So we have changed those out. But those kinds of things are quite acidic, and they will lead to demineralization of your tooth. But the fluoride in toothpaste helps remineralize
Yep.
your teeth. So while we know women's pH is lower and lower pH can cause some issues, there isn't enough research to prove any links and whether women need to actually do anything differently to achieve better dental health than what we already do.
Yeah. Look, I'm not a dentist.
What?
I'm not a
Don't
dentist.
GPs do everything?
I actually hate teeth-related issues. But I am a GP who likes good science and strong enamel. So basically, women have slightly more acidic saliva than men. So we're more doomed to cavities, plaques, gum disease, and apparently toothpaste isn't even made for us. Big claims, but tiny evidence to support them. So dentists are very clear on this. There's no solid evidence linking these small saliva pH differences to worse dental outcomes for females. Toothpaste isn't gendered.
I mean, it kind of is. If you're looking like...
Is pink toothpaste a little bit more expensive these days?
I presume so.
Yeah.
Like there'll be like
pink is a more expensive colour.
like lady shavers as opposed to men shavers.
Yeah. It's formulated around fluoride, which helps remineralize enamel for everyone. So what matters, I think, far more is our diet. So candy
and soda.
Diet, sugar, acid exposure. I remember my dentist was telling me, because I used to have like water and I used to put like lemon pieces in it or put a little bit of lemon, and he said that was bad for my teeth. So I've had to cut back on that. And just making sure that we're brushing our teeth and seeing our dentists often. So, yeah, but definitely more research needed in the area, as is lots of female research.
I know. We've said this a few times over this past year or two.
There's probably like 50 trials pending based on just the podcast we've done.
I think so,
Yeah.
right? But yeah, I mean, it's important that you brush your teeth, brush them properly, floss. Don't brush your teeth too hard.
Yeah.
Like I went to the dentist years ago and I was like, oh, my gums are quite sore. I don't know what's going on. And they're like, you just need to calm down. You're brushing your teeth way too hard.
Yeah.
You can end up with receding gums. So like gentle is the best approach to that. But yeah, our pH levels, not enough evidence at this point. Okay, let's get into today's checkup topic.
It's time for the checkup.
We're looking at why sex can be painful and what we can do to make it just not be.
Or fun.
Or fun even. Yeah. All right, hands up if you've ever had sex and it hurt. Yes? Yep, everyone in this room. I'm presuming quite a few of you listening. It's probably been painful too. It's a pretty universal experience for women, but we don't tend to really talk about it.
Yep.
So when someone like Meghan Trainor, who is a huge celebrity, comes out and talks about it, it was quite shocking, but she made a painful sex confession on her Working On It podcast a couple of years ago. Have a listen.
I thought that every woman walking around was always in pain during and after sex. I was like, Doc, are you telling me that I could have sex and not feel a single bit of pain? And
Oh
she
my
was like,
God.
yes.
So she explained that her doctor diagnosed her with vaginismus. So Mariam, do you have people coming in to you dealing with painful sex issues, or do you feel like this is still something people are a little bit reluctant to talk about?
Both. It's rarely the first thing that they'll mention, or it's something that I kind of will push to get an answer to.
Yeah.
And usually it comes up right at the end of an appointment. If it does come up, I'm like, oh, one more thing. And, you know, like kind of said in a lower tone and head down. So the topic still carries a lot of shame and silence. Most females think that painful sex is normal and something that they just have to accept. Maybe because they feel like I've had kids, I'm going through menopause, or they've been really stressed or something traumatic has happened and it's just become the norm and this is how it is.
Or it's like, it's a me problem.
It's a me problem.
So I'm just going to have to
just
suck it
deal
up.
with it. Yeah. But painful sex is never something you should have to put up with. It's really common and there are so many possible causes, from hormonal changes to dryness to pelvic floor tension, infections, psychological factors like anxiety, past traumas, even relationship issues. Our bodies and minds are so deeply connected, and sometimes pain is our body's way of saying, hey, something needs some proper care and attention here.
Yeah, and often we ignore it until it's like slapping us in the face.
Yeah.
Which is not the best way to deal with your health issues. So how would you want your patients then to come in and bring it up to you? Because it isn't an easy thing to do. But what kinds of, vaginal or psychological data would help in this situation? What can we arm ourselves with before we go in?
I don't want people to think like you need to be fully prepared for this conversation. So I just want you to come in and start the conversation. You don't need to have everything figured out before you come in. You can simply say to me, sex has been painful or uncomfortable lately. And that's enough to start the conversation. I know it can feel awkward to say it out loud. You can write it down or you can mention it while we're talking about something else. And my job is to make sure that you feel safe and supported in the environment while we work out what's going on. But generally during the consult, there's like a bit of information. So something to think about. So these are questions that I would ask to try to understand the full picture. So where is the pain? Is it at the entrance? Is it deeper inside, or is it both? What happens? Is it every time with penetration, or is it only sometimes? What does the pain feel like? Is it burning? Is it tightness? Is it a sharp pain, or is it an aching pain? Are there any physical changes that you're experiencing, like vaginal dryness, vaginal discharge, any itching or bleeding? And then the hormonal context is really important. Are you breastfeeding? Are you perimenopausal? Are you on contraception? Are you on any medication? And then psychological factors are really important. So any history of trauma, sexual assault, traumatic births, anxiety, depression, relationship stress, or even abuse that might be affecting how your body responds. So the combination of physical and psychological information kind of gives us a really clearer picture and helps structure the consult. And then from there, we take gentle step-by-step approach, and that might mean figuring out what to do next, whether that's a trial of lubricants or vaginal moisturizers, treating infections or hormonal changes if that's what's happening, referring you to a women's health pelvic floor physiotherapist if we think there is an underlying muscle issue, or connecting you with a psychologist or a sex therapist if we think there's trauma or mental health issues there playing a role. The key message is you're not alone. There's always something we can do. Painful sex is a signal, it's not a sentence. And with the right support, you absolutely can go back to having comfortable sex.
I think the thing is when you do go in to see a GP to talk about things like painful sex is there's this presumption that you're going to end up in the stirrups and someone's going to be looking at your vagina.
Yeah.
And I think that's what puts a lot of us off because we go and do our, cervical thing every 5 years and that is like sometimes you've got to psych yourself up to get to that point. So the thought of having that conversation or bringing it up and ending up on the table with someone looking, sometimes I think that's a bit daunting. Would you say that you would automatically expect that to happen in that situation?
No. So sometimes it's the first consult is just a conversation, and then we'll send off and do investigations. And even with people who have vaginismus and need to do a cervical cancer screening, sometimes preparation for that test is really helpful, and there are ways and things that we can do to make those examinations more comfortable and easy as well. So I would definitely start with a conversation and I wouldn't worry about the examination. So it would be a step-by-step approach, and if we were to do an examination, it would be with, your engagement and we'd be talking you through it. And there are things that we can do to prepare for the examination to ensure that there's no pain if it was an internal examination.
Okay, well, that is good to know. All right, next we are speaking to Dr. Karen Freilich about all the ways in which sex can be painful for us and how we can address some of these more common ones.
I'm Kate Langbrook and I host No Filter. Celeste Barber. Hi. Welcome to No Filter.
It's nice to be here.
Yeah, today we're diving into the world of G-Flip.
And your voice has always been such a calming, warm energy. So that's why I tear up because you're always growing up with you around. So thank you.
Sally Hepworth, what a absolute jewel you are in the crown of artists.
Oh, thank you. This has been lovely.
Today, we're talking to Rosie O'Donnell.
I just want to tell you, this is one of the best interviews I've ever had.
If you love conversations that go deep and stories that stay with you, listen to No Filter. New episodes of No Filter drop every Monday, wherever you get your podcasts.
Dr. Freilich is a general practitioner who works as a sexual medicine and therapy consultant. We kicked off our chat by asking about what's happening to us when we experience dyspareunia. That is the medical term for painful intercourse. Karen, thank you so much for joining us today to talk about all the reasons why sex might not be as comfortable as we would like it to be. So welcome to Well.
Thanks for having me. I'm really excited to be here.
Well, let's start off with the basics. When someone says sex is hurting, what could be happening beneath the surface there?
It's a really, really good question, and it's a huge question. And I think to start us off, the way I want to frame this conversation is to ensure that when we're talking about sex, we're talking about consensual sex. So sex in which there's free, voluntary, and informed consent. The reason I always start off talking about this is when we're talking about painful sex, we always want to frame it to make sure we're talking about consensual sex, because one of the reasons people do present with painful sex is that it is non-consensual sex. So always want to get that out of the way and make sure that we're framing it properly. But when we're talking about painful sex, there are so many different things that can contribute to it. So this conversation is specifically about people with vaginas, so people who are assigned female at birth. And when we're talking about penetrative vaginal intercourse, you can get pain for many, many different reasons. And a lot of it's to do with the anatomy. So it could be external factors, internal factors, it could be psychological factors, social factors, and it differs to everyone. So it's a really, really big and complex discussion.
Well, we'll try and drill down into some of those because you're right, there is a lot to cover. But I wanted to get you to distinguish for us too, because I understand there are different types of pain that we should know about. So entry pain and deeper pain. Can you just give us an idea of what that means?
Yeah, 100%. So if we're looking at the anatomy of the vagina, so we've got the external vulva Then we have the internal vagina, and then we've got the uterus, and the entrance to the uterus is the cervix. And then we've got all the muscles around, and we've got the pelvis as a whole structure. So when we're looking at pain with sex, all the different places pain can come from is all those different anatomical structures. So we can start with external. So is it the vulva itself that's uncomfortable? So it could be dermatological conditions, things like lichen sclerosis that might be, I guess, undiagnosed. It could be vulval dermatitis, so irritation, itch, thrush, STIs, BV, anything that's kind of causing irritation, even things like hair removal, poor genital hygiene, so anything external. And then when we're talking about the vagina itself, there's a few different factors. So menopause and perimenopause, so what's called genitourinary syndrome of menopause, can lead to a low estrogen state, therefore leading to vaginal dryness, discomfort. That can lead to discomfort with sex. Same thing applies to breastfeeding. Similar thing applies to breastfeeding. And then when we're talking about kind of the uterus and the ovaries and all those surrounding structures, we have any type of gynecological pathology. So those could be cysts, it could be endo, it could be fibroids, it could be anything that's causing drama. Then we zoom out to the pelvis, and could it be that the bladder has some drama going on, so painful bladder syndrome or bowel conditions like Crohn's, IBS, and then are hip issues, are there kind of pelvic muscle injuries happening? And then putting that all together, we know that the pelvis is held together by a whole bunch of muscles that are kind of circling around the vagina. So the vagina is kind of like for lack of a better phrase, like a sock. It's just a little tube, but there's muscles all around it. So if those muscles are tense and there's muscle tension there, those will tense up and that will cause pain. So many different causes, often really intercorrelated as well.
If it's something deeper like, say, endometriosis or pelvic inflammatory disease, things like that, are there some warning signs that we can look out for when it comes to experiencing painful sex that might lead us to better understand what the cause of it is?
Yeah, and I think this is a really, really good question, because I want to delineate two separate things. There might be objective, tangible causes of pelvic pain, but there also might not be. And both things are equally important. So when we're talking about objective, tangible, and often treatable causes, those are things like endometriosis and, of course, pelvic inflammatory disease. And you'd be pretty unwell if you had that, but we can get to that. But then there's also subjective causes. So often when people present with pelvic pain or pain with sex, so dyspareunia, there's often this real need to find out, well, what's going on? Is there something underlying? What's the cause? And often we don't find a cause. So when we're doing lots of tests, we're trying to rule out anything that we can treat, anything that might be kind of dangerous or anything that might have sequelae. But simultaneously, we might find nothing, and that is still a very valid presentation, and it's still a diagnosis in and of itself. But warning signs to look out for, so any type of abnormal vaginal discharge, so any malodorous discharge, so really smelly discharge, green discharge, an unusual change in your discharge, bloody discharge, blood in between your periods, or any bleeding after sex, or even just pain that feels really unusual, systemic symptoms, so feeling feverish, feeling unwell. Always good to chat to your GP, your doctor about it.
Well, let's talk about something that it's not necessarily a physical symptom, but a psychological one. So I have had some friends who have gone through vaginismus issues, and for some of them it has been it stemmed from a psychological place. So how does mental health or past trauma, for example, come into play when we're talking about experiencing painful sex?
It's a really good question. And I think to answer it, it's really important to kind of go back to pain science basics. So why pain happens and how it's related to trauma. A trauma is an incredibly important part of this discussion, and I will continue to bring it up because I think it's really important. I'm glad you did bring it up. Though I wish it wasn't a conversation we always had to have. But to put this into perspective, in Australia, about 1 in 5 women above the age of 15 have experienced sexual violence. So this is incredibly common. So when we're talking about pain science basics, is when there is some sort of injury to the vagina, to the pelvis, and that could be psychological, it could be mental, it could be physical, you're going to experience pain. And that will be those muscles tensing up to try and protect your pelvis. So when those muscles tense up, it's protective. But when you have too much pain, it's those muscles being overprotective. So the metaphor we often use is a car alarm. So anyone who drives and is a fairly safe driver would have a little car alarm at the back of their car to beep if there's a car driving past them or a pedestrian or a bike to say, hey, slow down or stop the car. And the car alarm is there to protect you, right? In the same way that your muscles are there to protect you, to tense up, to say, hey, something's wrong. But if that car alarm senses a lot of danger, that car alarm might start to go off inappropriately. It might start to go off all the time. It might start to go off and become really hypersensitive. And that's when the pain is becoming overprotective. So we know that if you have an experience of pain or any unwanted experiences, your body will tense up to protect you, but then with time will become overprotective. So again, pain is a protective process. It's just becoming overprotective with time.
I'm presuming that's similar to, but not exactly the same as women who have experienced, say, a traumatic childbirth experience, or even not necessarily traumatic, but landscape might have changed, for example, stitches in places where have left scars where there weren't before. And so there's physical changes, but also the psychological changes that go along with that. So I'm presuming childbirth can lead maybe to some painful sexual experiences down the track.
Yeah, so childbirth is a really interesting one. And I think a good place to start with this is that anything that leads to pain in the pelvis can create this cycle. So trauma is one of those things, childbirth is one of those things, but even a painful tampon, having diarrhea, having a bad UTI, having painful periods, anything that leads to pain in the pelvis can create that negative feedback loop where there is that negative feedback loop of fear and avoidance and catastrophizing pain. So childbirth, and I will say it time and time again, childbirth and pregnancy is the most dangerous thing anyone with a uterus can ever do. And it's still a very wonderful and exciting thing. But what can happen is in childbirth, you can have changes to the anatomy in order for the baby to come out. And that could be an episiotomy, it could be a tear. There can, of course, be birth trauma as well. And the body has an incredible capacity to heal, but for some people in some situations that can take quite some time, require a lot of pelvic floor physiotherapy. It might require things like vaginal moisturizers, lubrication, and in some situations also vaginal estrogen, of course, chatting to your own doctor. Bearing in mind that people who breastfeed will also have a low estrogen state in their vagina, and that can lead to some discomfort as well. There can also be a change in relationship with your vagina and vulva. So thinking of it in a totally different way, the anatomy's changed, having a different relationship. And then on top of all of that, there's a baby in the mix. So these things are always really multifactorial, but really important to have a really good team. So pelvic floor physio, GP, gynecologist, psychologist if relevant. But childbirth is a huge, huge factor.
Speaking of pelvic floor physios, I'm really intrigued about what actually happens behind those closed doors. But a lot of us do pelvic floor exercises off our own bat just to, keep things in places where there should be. But can you take that too far? And could that then end in painful sex?
Yeah. So if you want to think about working out in general, so if you go to the gym, and good for you if you're working out in general, you're always using your muscles, you're strengthening those muscles. But you also need to do some warm-ups and stretches afterwards, right? So you can't just strengthen the muscles, you also need to relax them. So with any muscle in your body, we should build up those muscles, we should strengthen them if we can, but simultaneously, you've also got to relax them. So when we're talking about pelvic floor exercises, and pelvic floor physios are the absolute geniuses with this, is we're talking about strengthening the pelvic floor, but we're also talking about pelvic floor relaxation, pelvic floor awareness, and also reducing the tone in the pelvic floor. So it's doing one and the other as well. So can't just strengthen without also relaxing.
You've mentioned vaginal estrogen as one way to help women who are in menopause or perimenopause with vaginal dryness. But what if you're not in that stage of your life and you are experiencing dryness? What can we do to help that?
Yeah, a really, really good question. And first and foremost, it's always important to see your clinician, GP, first to rule out any kind of pathology, right? So sometimes people have vaginal dryness and it can be psychological, could be really multifactorial, but there could also be some really treatable things going on. So having examination, getting some tests is really, really important. And there's a few different things. So vaginal dryness is an interesting one because when we're talking about sex specifically, the vagina lubricates up. So it becomes moisturized because of, physiological arousal. But in order for that to happen, you need to feel turned on enough, you need to feel comfortable enough, but also sometimes you need some extra help as well. So for some people, it might be kind of high quality vaginal moisturizers. And I would say speak to a clinician before you buy anything online. But then using really good quality lubrication during sex, I really cannot emphasize lube enough. And without kind of saying any specific brands, it's really important to get some really high quality lubrication, finding the one that works really well for you and the type of sex you're having. Lubrication should not be something that's taboo at all. Lubrication improves sex, improves the quality of sex, and improves comfort throughout sex. But if you're not turned on enough, if you're not comfortable enough, no amount of lubrication can help that as well.
All I can think about when we're talking about vaginal dryness is when you put in a tampon that's maybe too much for the flow and then you have to pull it out and it's not got enough blood on it to allow its release. Like that, like it's making my teeth hurt even just thinking about it. Vaginal dryness can be quite traumatic when you think about it.
It can be. And look, I think it's interesting you bring up tampons because I think tampons is a really good metaphor to try and understand sexual pain. Because I think, many, many people listening to this podcast have probably tried a tampon before. And if you think back to when you were a teenager and using a tampon for the very first time, the experiences differ a lot. And I think back to when so many people were using tampons. In order to use a tampon, you need to feel kind of safe, you need to feel comfortable, you need to relax your pelvic floor. If you have messages around you, people saying, oh, tampons really hurt, you shouldn't use them, or slut-shaming people who have used tampons, which is a thing that's out there. It's wild. Yeah. It's absolutely wild. And if you get told these messages that tampons will hurt, like it won't work, and you tense up and you feel uncomfortable using it, and it hurts to put the tampon in, then lo and behold, every time you try to use a tampon in the future, it will hurt or you'll just avoid doing it. So I think the experience of putting a tampon in is so symbolic of what it means to have a tense pelvic floor and to relax that pelvic floor and that kind of mind-body connection.
It's also for some people the first time they realise that they differ in anatomy down there because you don't spend a lot of time in the depths of your vagina before you become sexually active, but the first and maybe only time you do until then is to insert a tampon. So I've had friends who've like, oh, this is how I found out that, I had a tilted uterus or whatever it might be. It's like the first time you kind of discover what's really going on.
100%. And look, I wish we had way more education in schools about kind of what pelvic anatomy is. And I think for anyone who has testicles or, a penis, you look down and it's right there. You can't avoid it.
There's no mystery.
No, there's no mystery. It's really quite there. But if you have a vulva, unless you're incredibly flexible, you can't really see your own anatomy. And so what happens is that it creates this invisibility where people don't know their own anatomy. They have to go out of their way to see their own anatomy with, a mirror, a lot of flexibility. And then even then, there's not enough education to really delineate what everything is. And so much of this is getting people comfortable with their own anatomy, understanding their own anatomy, the differences and all the different elements of the vulva. So I wish we had more education on that. It's so important.
So she talked a little bit about pelvic floor physios there. And Mariam, you have gone to see one. And as I said to her, I'm intrigued about what actually happens. Like how, I go to a physio because I have a knee issue and I'm very comfortable with what she's going to touch and manipulate. Yep. But how does a physio help you with your pelvic floor? And how do they even access that? What are they doing?
So with the twins, I got later to term. They were quite big babies and I delivered them vaginally. I knew I was going to have a weak pelvic floor and I couldn't link in, unfortunately, to a physio at that time because it was COVID and COVID sucks. And then I just got busy and life happens. And then with this pregnancy, with the hyperemesis and the vomiting, I was urinating.
Oh, because the pressure is pushing.
Because of the pressure. It was so... oh, my goodness, confronting when you're about to vomit and then you're urinating.
And you can't focus on holding your bladder in when you're vomiting, right?
But can you imagine? No, you actually lose control. Yeah. So I was like, okay, I need to do something. Mm-hmm. I'm in my 30s and I'm having a child. Yeah. And I had to live in pads. I'm going to work and I'm urinating. It happens. Like, these are conversations we need to have.
Yeah.
And so I was like, nope, I'm not going to leave it this time. So I saw this amazing physio at the studio in Rizal. And in the initial consult, she did an internal exam. Okay, which a lot of people aren't aware of, but it's so important. And I'm so grateful she did. She even held up a mirror to show me what was happening.
Okay.
And I think that I learnt so much from actually being able to see what was happening.
Mm-hmm.
The pelvic floor, it's a group of internal muscles and you can't assess them properly from the outside. So you need to see what's happening, right? She also wanted to check my technique for pelvic floor exercises because
we had a chat about this the other day, right? Because you can do them all you like, but if you're not doing them right,
exactly,
it's not good for you.
So I've been the doctor that's been telling patients, you can look online on videos and start them 6 weeks postpartum if you've got clearance. And that's what I've been doing as well. So, I've been just doing them randomly, sporadically without any physio guidance. And I was clenching everything except my pelvic floor. So when she showed me, I thought I was doing a pelvic floor exercise. She pulled up a mirror and I saw things were coming down.
So you're pushing out rather than pulling back in.
Yeah, I was actually making it worse. So you can say, yep, I nailed it. I'm doing my Kegels like a pro. I'm doing these videos. But unless you know how to activate those right muscles, you're not doing them right. And the only way to really know that is if you see a pelvic floor physio and they assess you to make sure that you're doing it right. It's clinical, it's respectful, and it's generally empowering because suddenly you know your body better and you can actually train it properly. I honestly think they're worth their weight in gold. They're underutilized. A lot of people are seeking these online services, and I cannot say to you enough, even if you just go in for a one-on-one initial assessment, it's so important. You get over that initial awkwardness, and it is honestly one of the most useful health appointments I've ever had. Yeah.
Amazing.
Yeah.
On the way, next, a quick consult for Kayla, who wants to know what Mariam sees when she goes in for her cervical screening.
Hello, Holly Wainwright here. I'm an executive editor at Mamma Mia, and I have been part of this business, an independent women's media company, for more than a decade now. I have seen a lot, but being independent has always meant that we don't have anyone telling us to play it safe or to avoid the topics that feel a bit too messy or uncomfortable for a boardroom full of dudes to handle. And I never take that for granted. If we help you feel a little bit less alone or more connected through the conversations with fascinating women that Kate Langbrook's having on No Filter or one of our other shows, or if we help you feel more informed with the stories that your group chat is really reading on the Mamma Mia app, please consider, please, becoming a subscriber. Because your support really helps us keep telling the stories that matter to Australian women. As a Mamma Mia subscriber, you get unlimited access to everything. Every article, every video, and every single podcast we make. You can even move with me. Subscribers get full access to our at-home fitness app, including my new weights program launching soon, I promise, with an expert and not just me. Subscribe to Mamma Mia today. Support independent women's media. There's a link to do that in our show notes.
All right, let's get into Kayla's question, Dr. Mariam, if you will.
The doctor will see you now just through here to consult room 1.
Thanks for waiting. How can I help you?
If you do have a question for us like Kayla has today, you can send it in a few ways. Hop into the waiting room. That's the online form in our show notes. That's how Kayla got her message to us. You don't have to tell us your name. And if you don't, I give you a fun alias instead. So that's why Kayla is called Kayla today, because she did not want to give us her name. You can email well@mamamia.com.au, or you can hit us up in the DMs on Instagram or TikTok. All right. Kayla is concerned, Dr. Mariam, and she has asked for you to specifically answer her burning question about what can be viewed during a consult. She wrote this.
I need Dr. Mariam to tell me truthfully what she sees when I get my gynae check done. I know that my doctor would see my vulva and vagina and cervix and just all up in there, but can you see my butthole? I don't know why I need to know this, but it's freaking me out. Please just tell me.
Okay.
And I think I know the answer to this because I saw a Tumblr thread about this once where a woman said she puts a butt plug in with a googly eye on the end of it every time she goes in to see a gynecologist.
So good. I love it. All
right, what can you see?
Okay, so when you come in for a gynae check, I usually prop my patients up and I put a pillow under their lower back just to get them in a good position. So when I put the speculum in, I can actually see the cervix.
Yep.
So I see your vulva, and if it's for a cervical screening test, I see your cervix. That's the main event. That's my main focus. Look, your butthole, it's there, but I'm not actively studying it, okay?
Yeah,
and
but like you're close to it, right?
Yeah.
Like you can't not see it.
They're the vulva and anus. They're next door neighbours.
Yes.
So like it's in view, but here's the part you need to hear. I'm not looking at it. I'm not judging it. I'm not even really registering it. My brain is like super focused. I'm like, find the cervix, get the sample. Don't let the swab touch the sides. Your doctor isn't down there thinking like, oh, look, there's a butthole. We're thinking good lighting, speculum angle, don't let the swab touch the wall, success, yay, I got a good swab. I care more about whether I remember to take out the washing out of the machine than I do about your butthole, okay?
Yeah.
Now, the googly-eyed butthole plug, is it clinically necessary? Absolutely not. Is it hilarious? 100%. If you did do that when you saw your GP, I will break professional composure for about 0.5 seconds and then I will continue along like it's completely normal because healthcare honestly it kind of is. So your doctor's not analysing, they're not critiquing, we're not rating your butthole, we're not ranking, we're not even emotionally registering it. It's there, but we're not looking at it, I promise you, okay?
Right. Although you are being watched if there is a googly eye on the end of the butt plug.
So just breathe and unclench. Please.
Okay, so Kayla, she can see your butthole.
Yeah.
But she's not looking at it.
No, not looking at it.
And doesn't care anyway, even if it is. Okay. Thank you, Mariam. And thank you all for spending time with the good doctor and I here today. The info you've heard here is general, so it's not fully for you, but it could be. You just got to take it to your doctor and find out. Before I tell you what's going down next week, though, could you do us a solid and rate and review us in your podcast app? I know. Please. You probably get asked it by like every podcast you listen to, but it does actually really help us both to understand what you're loving or not loving about the show, but it also helps us get discovered by other women who might be looking to find some better info on the state of their health too. So pop in a rate and review and Mariam and I will be your BFFs forever. Next week, our Mariam here is in the driver's seat. She's sitting down with Chantel Otten because remember a few weeks ago we asked if you could ask any question to a sex therapist, what would it be? Well, y'all did not hold back. So we have some great questions from you to put to sex therapist Chantel Otten. That's coming your way next week and we'll catch you for your appointment then.
Bye-bye.
Mamma Mia acknowledges the traditional owners of the land we've recorded this podcast on, the Gadigal people of the Eora Nation and the Wonnarua people. We pay our respects to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander cultures.
If you, like the rest of the world, are watching Euphoria, Mamma Mia has your new obsession. It's called Watch Party, and it's the podcast dedicated entirely to breaking down every episode of the new season. We drop a new episode every week, so you get instant deep dives, hot takes, and superfans unpacking every twist in real time. Search Watch Party wherever you get your podcasts and hit follow so you don't miss a thing.